Appreciate it. Okay, so very quick introduction to the CP Research Network, and then I'm going to turn it over to Elizabeth Boyd and from CP Alliance Research Foundation, and then we'll go into the study presentations. So just briefly about the CP Research Network, our mission is to optimize the lifelong health and wellness of people with CP and their families, and we do that through high-quality research, education, and community programming. One of the first things we did when we were formed was we ran a patient-centered research agenda process that was called Research CP. This is the group gathered in Chicago in 2017, and that produced a paper called Setting a Patient-Centered Research Agenda for Cerebral Palsy. We've actually done 3 of these now, and these research agendas really drive our work. The vision of what we do is that we engage the community, a very large number of community members and a large number of health systems in a learning health network, i.e. hospitals that share the data for the care to improve the care continuously, with it very focused on cerebral palsy. And it's a focus on not only conducting research, but improving care. So research answers questions, improving care improves outcomes for people with CP. And we focus this on these issues that were raised through the Research CP process. So focus on participation and quality of life as being big key factors. We gather a lot of lived experiences, and then we measure the healthcare that's provided to create a platform for continuous improvement about those issues that people care about most. So tonight you're going to see presentations from a program we have called Accelerator Awards, but there's a special one that we've done in partnership with CP Alliance Research Foundation called Changemakers. So Accelerator Awards are $25,000 awards intended for the CP Research Network investigators with a goal of rapidly advancing new ideas to sort of change the landscape. The concepts must address something that are in one of these, 3 research CP themes that we've done. And we've been in the process of establishing a regular way in which community co-investigators can both vote on which of those concepts are most important and participate in the research. So what you're going to hear tonight is about 3 top concepts that were winnowed down from 9 that were presented a few months ago to the network. I'm going to turn it over to Elizabeth to talk to you a bit about the Changemaker program and about the process. So take it away, Elizabeth. You should be able to share.
Okay, can everybody see my screen all right?
Yep.
Okay. Hi, and welcome to our inaugural Changemakers Grant Pitch event. I'm Elizabeth Boyd, Director of Development at the Cerebral Palsy Alliance Research Foundation. At CPARF, we believe science works best when it's shaped by the people it serves. We do this through the development of research pillars, community roundtables, and the co-creation that occurs during our Assistive Technology Accelerator, Remarkable US. And now with our Changemakers Grant Program. This is your chance to have a say in the next research study we fund. For this year's Changemakers Grant, we worked with our strategic partner, Cerebral Palsy Research Network, using an accelerator grant model where deliverables are completed within 1 year. Over the past few months, research teams have submitted grant proposals that were scientifically reviewed for overall impact and graded using NIH scoring, including significance, innovation, and approach. We hope that this encourages novel and academically sound ideas that create a cascading effect across the research landscape. We believe that novel ideas begot transformational change. So tonight, you'll hear from the top 3 finalists. They'll present their studies, and you'll have a chance to ask them questions directly. So without further ado, let's begin. Our first presentation tonight is from Dr. Richard Stevenson at the University of Virginia, who will be discussing growth and the quality of life in children with CP.
Okay, thank you, Elizabeth, and thanks all for the opportunity to share our work. Okay, you should be seeing my my presentation. Is that right?
We're seeing your Outlook right now, your Outlook calendar.
Well, I pushed the wrong one here.
It's
Let's
okay.
try it.
Blaze the path of incorrectness. There you go.
That better?
Yep.
All right. Okay, let me get it in a way that I can see it now.
Now we can't see it anymore, Rich.
Yeah, we're seeing your Zoom on your browser. There you go.
Sorry. Okay, let me jump in then. Well, it's a pleasure to be here on behalf of my colleagues to talk about growth, health, and quality of life in children with cerebral palsy. I'm sorry, I'm having trouble here with my technology. Can I try something else?
It's working in terms of where your background and introduction screen. You might have to go to single screen to get it to work the right way, so you don't. But we can see background and introduction now.
Yeah, Rich, it's something with Charlottesville's internet right now. I got kicked off and had to log back on. I don't know what's going on.
Egad.
Does that work? Can you see that?
Yep, we see background and introduction.
Okay, this works for me too. Okay. All right, so back to zero. Here we go. It's a pleasure to be here on behalf of my colleagues from UVA, from Children's Hospital of Philadelphia, Nationwide Children's, and from new colleagues with lived experience.
Stop. It does not.
It's okay, I'll get them muted, sorry.
Okay, and those with lived experience who are part of this project. So this proposal describes next steps in the evolution of a research program on nutrition and health in those with CP. And the goal is to link objective indicators of nutritional status with measurable outcomes that matter, that ultimately will help us improve the health and quality of life in kids with CP on into adulthood. The work really needs CPRN because we need observational studies with large sample sizes as a foundation for later clinical trials. So that's what I hope to describe to you. And I'd like to illustrate how this will contribute to important new knowledge that, again, ultimately will improve health outcomes. So we have two specific aims. One is to determine availability of weight and GMFCS data in the current CPRN clinical registry, plus health utilization outcomes that we can pull out of it as a foundation to be able to predict health outcomes based on weight percentile, thus linking a specific nutritional indicator, weight, with important outcomes for future studies. And then secondly, in order to sort of broaden our ability to do different kinds of studies across all GMFCS levels, both under and over nutrition, to try to determine other additional nutritional indicators beyond weight, plus additional outcomes that will serve the cause of, again, linking nutrition to important outcomes. So the way this is typically done initially, let's just jump in with an example. So typically we monitor growth in children by measuring weight and height and putting them on a growth chart and comparing them to typical reference population of children. So this illustrates one of my patients, an 11-year-old girl I saw in clinic last spring, plotted on a typical weight chart from the CDC. This is how all children get monitored in their pediatrician's office. And this particular chart shows from the 3rd percentile at the bottom to the 97th percentile. And this girl, as you can see, throughout her life has tracked along the 3rd percentile, and then over the last few years has started to fall away. So most pediatricians would look at this and draw concern about this because this child does not appear to be growing ideally. So a fundamental question here is whether a typical growth chart, that is a growth chart based on typical children, is appropriate for use in children with cerebral palsy. Well, many have considered this, and there are now CP-specific growth charts that have not been widely used, but they have been in existence since 2007 and then modified in 2011. These were developed in California based on a large number of children. And the unique aspect of these growth charts is that they are specific for GMFCS levels. So there are essentially 6 growth charts, 1 through 5, plus 5 with G-tubes existing for each boys and girls. And the unique aspect of this is that those children in GMFCS levels 3, 4, and 5 who are below the 20th percentile compared to other similar children have an increased rate of mortality over the subsequent 3 years. That's what the research showed. This is a unique finding linking a specific nutritional indicator, weight percentile, with a specific outcome measure, mortality. Now, while mortality is not my favorite outcome measure, it definitely is an important one, often used in medical research, and is a beginning in terms of trying to tie growth to some kind of outcome measures. Now, these haven't been used very broadly for 2 reasons. One, because after their publication, the world shifted from paper growth charts to electronic growth charts. And if it's not in your electronic medical record, you're not going to use it. And then number 2, it hadn't been validated. So recently, work with some of my colleagues and in work that will be published soon in pediatrics, we were able to validate these growth charts with a separate data set of children. So by validation, on the left side of this slide are the girls, on the right side are the boys. It just demonstrates that the growth charts are appropriate for kids with CP, and that the data set is statistically significant in terms of it serves the population better than the CDC growth charts. Furthermore, we were able to demonstrate that those children who were below the 20th percentile, in addition to the work that had previously been shown of increased mortality, also were more likely to have been in the hospital overnight in the 4 weeks prior, to have missed their usual day program, meaning school, missed after school activities, and the family significantly had missed many activities. So based on this pilot data, we've been able to demonstrate and broaden the idea that links a specific nutritional indicator, weight percentile, with outcome measures related to mortality, healthcare utilization, and participation in society. So back to our example. Again, this growth chart suggests that this child might require some kind of intervention. When we plot this on the CP growth charts, the child looks like this. What this demonstrates is that over this child's lifetime, she has basically grown very consistently between the 25th and 50th percentile compared to other children with her same level of cerebral palsy, suggesting that she seems to be doing okay. Now, is that the final answer? Well, not exactly, because, honestly, in looking at her, I was concerned that she looked pretty thin, did not have a lot of extra body fat. And so I looked at 2 other nutritional indicators, tricep skin fold, which was at the 5th percentile. So on the low side, but still in the normal range, mid upper arm circumference, which captures both lean mass, that is muscle mass, and fat mass. And she was at the 10th percentile for that. She was actually very muscular and strong, having mostly dystonic cerebral palsy. So with this as so this is one example of how we might guard against, how we might interpret those who are at the lower end of the nutritional spectrum. How about children who might be doing a little bit better? So this is GMFCS level 2. This is another one of my patients, a girl who over the last few years, basically had tracked along the 50th percentile for other kids with GMFCS2, but then is starting to gain weight And in fact, when I did an additional marker of nutrition, her tricep skin fold was actually on the high side at the 90th percentile, putting it at some risk if that trajectory continues for becoming overweight eventually. So this gives you some idea of how these growth charts, which my hope will continually be in use, can at least provide an anchor or a foundation for further studies that will link nutrition with outcome measures. Now, there are a number of other nutritional indicators that can be used in addition to standing weight, weight on a chair scale, as we use in our clinics, mid-upper arm circumference, which captures fat mass and lean mass, tricep skin fold, subscapular skin fold, abdominal circumference, and then ways of measuring linear growth such as tibial length, and of course looking at puberty and staging of changes over puberty. All of these are nutritional indicators that can be added to weight as ways to mark progress. How we might measure outcomes in addition to mortality, in addition to healthcare utilization are listed here. On the left are those that we think may be available through the medical record in current CPRN clinical registries. And on the right are additional outcomes that might be useful that capture other aspects of health and quality of life, such as fatigue, pain, sleep, overall mobility. You might, for certain applications and certain studies, want to capture some Fitbit data, such as daily steps, as heart rate, and other ways of capturing quality of life, such as the CP quality of life instrument from Australia. This is just, I'm going to skip over this slide, but it just shows that we have done preliminary work using data from our CPRN registry, which had over 5,000 weights of over 2,000 children, and just shows how those kids are well represented in the CP growth charts. And again, that those kids who were below the 20th percentile were more likely to go to the emergency room, spend time in the hospital, and so on. So to summarize, I've tried to describe next steps of ways to connect the dots between nutritional indicators and outcomes that matter. We're proposing a study that goes across the spectrum of function, GMFCS 1 through 5, and the spectrum of nutrition from undernutrition / malnutrition, as well as overnutrition and obesity. We need observational data from a large clinical sample, such as we would get from the overall registry data, plus additional data in a smaller subset, which we can pull out specific sites to try out some different nutritional indicators and different outcome measures. This next step is going to require, I think, co-production as we have planned through the CPRN model. And I feel that successful completion of this project should set the stage for future studies, including nested clinical trials of nutrition, but I think might also help other investigators within CPRN in their use of weight and other nutritional indicators, both as ways to stratify patients for outcomes, or even using weight and other nutritional indicators as outcome measures themselves. So with that, I can close, and hopefully I've left enough time for a few questions.
Thanks so much, Dr. Stevenson. If you have any questions, feel free to raise your hand or pop them in the chat. We do have one already in the chat that I'll ask. How do you account for surveillance gaps? It is very common to forego weighing people.
Well, that's an issue. I think, though, we have shown that most, I mean, if anything is going to be captured in existing data, it's weight. That's the one that, at least in childhood, is captured more often than any others. But you're right, it's always an issue in terms of how much data you have.
Susan, would you like to go?
Hi there. This research is very interesting. Thank you. I'm an adult and unfortunately my height only got to 4'11 and a half inches. And it was always a problem in my life because not only did I have to deal with the cerebral palsy, but also the fact that I was so much shorter than other people. It made me, that was another thing for people to notice. And I'm hoping that in addition to tracking the differences, that this will lead to improved care that will get the kids with cerebral palsy up to the level of kids without a disability, height and weight wise.
Yes, thank you. My hope is that it will contribute to understanding exactly why people with CP do not grow as well, because there's really not it's not completely known. It used to be thought that it was all because of nutrition, but that's really not the case. It's not just nutrition by any means. It does seem to be something about the brain differences, and there may be lots of other factors contributing. So I hope we can understand that better, and as you say, make some changes.
Thank you, sir. I appreciate your efforts.
Thank you, Susan. Amber?
What age group is this going to consist of, and how are adults with CP going to be helpful to this if it's pediatrics only that the study is going to be looking at?
Yeah, I mean, my plan is to, for the most part, we're talking about 2 to 20, which is where the growth charts were created for that. But in fact, then to essentially join forces with others who are studying similar issues in adults to try to understand. My goal is to kind of set people up for successful transition to adulthood, and having what they need to have enough energy to work, to live the way they want to live, to do the things they want to do, and understand kind of both ends of the spectrum, the undernutrition side and the overnutrition side, and then find the happy medium in between. So understand where do the different indicators tell us that there's an impact on health, just to inform the impact that differences are having on individuals' lives, so in hopes that we have something that's modifiable that we can improve.
Okay, thank you.
All right.
Thank you.
Thanks. I think if anyone has any questions, you can feel free to email them to me. I'll give my information at the end, and I will circle back with the teams before voting closes. So up next,
Thank you.
Thank you. Our next presentation is from Dr. Lisa Letskis, also representing the Cavaliers of the University of Virginia. She'll be discussing automated infant movement screening for CP risk.
Thank you so much for the opportunity to share our idea with you guys. So as you guys all know, cerebral palsy is the most common lifelong physical disability, and every hour a baby is born with cerebral palsy, and upwards to 1 million people are living with CP in the United States, and I think upwards to 50 million worldwide. So the range of severity, is a spectrum. So majority are walking, but then there are some that use predominantly wheelchairs and also have other comorbidities that impact quality of life. Early interventions can really lead to improved outcomes. But most patients, even today, are still diagnosed way later than 12 months of age, which there's also noted disparities in access to care that still persist. Given current delays in diagnosis, as well as disparities, strategies in facilitating early intervention on the large scale are urgently needed. These pictures are of one of my patients, 7, Rose. He was born extremely premature at 25 weeks. So that's 10 weeks early. And he spent the first 6 months of his life in our NICU. So we'll hear more about 7 later. In 2017, guidelines were published on early CP identification. And this was really a landmark paper. And in these guidelines, 3 tools were highlighted as having the best ability to identify patients at highest risk. And that is the brain MRI, the general movement assessment or GMA, and the Hammersmith Infant Neurological Evaluation, or otherwise known as the HINE. And all of these tools can be done very early as up to 5 months of age to hopefully bring down that diagnosis. And why is this important? As I mentioned earlier, early identification matters, not only because to get the right services, but now we have extensive guidance on what interventions can be used for young children and infants with cerebral palsy that can optimize development, prevent further complications, and very importantly, support families, all during a time of where the brain is rapidly developing and has high plasticity. So this highlights like skill development, there's evidence-based interventions, there's complication prevention, as well as parental support that has been published. So how do we go from the current state of an average age of diagnosis of greater than 12 months to earlier? It is worth mentioning that success of the universal newborn screen and the newborn hearing screen, both performed prior to hospital discharge after birth, is achieving just that for multiple severe metabolic disorders as well as hearing loss. The newborn hearing screen in particular is interesting to look at into more closely because of the 1, 3, 6 benchmarks. So what does that mean? So 1 month is screening of all infants. That is their goal. And in 2022, 96% of all infants in the US were appropriately screened. Then the goal is diagnosis by 3 months of age with hearing loss and treatment starting at 6 months of age. In addition, there has been a large amount of evidence supporting improved outcomes and cost effectiveness with this approach. So going back to the 3 tools identified as best for early detection of cerebral palsy, we have the brain MRI, which can be performed prior to hospital discharge after birth, but it's not always available everywhere. And interpretation is notoriously challenging in this age group because you need specialized training and a pediatric neuroradiologist on staff. The Hammersmith Infant Neurologic Evaluation is validated for infants starting at 2 months of age or older, so this really doesn't fit our criteria. This leaves the general movement assessment as the best candidate for early screening. So what is the GMA? Infants with spontaneous movements. This is innate whole body movements that are involuntary and can be observed from birth up to 20 weeks post-term. These movements are, when normal, are indicative of healthy brain, and in contrast, if abnormal, can be highly predictive of cerebral palsy. So in this cartoon and table, you can see the normal progression of these general movements from writhing, which occurs up to 6 to 9 weeks post-term with a transition to fidgety. Here, we focus on the writhing stage because these can be observed in all infants prior to NICU discharge and before they go home after birth. These movements, they involve the entire body, and when normal, are fluid and variable as seen here.
I don't think so either.
Abnormal movements. Oops, sorry. Sorry, guys.
Being finicky.
Is it good? There we go. Abnormal movements, specifically those called cramp synchronized, are more rigid with all extremities activating at the same time. The presence of cramp synchronized are a high concern with regards to later diagnosis of cerebral palsy. The GMA is the classification system used to classify these movements. It's performed by trained experts and relies on subjective classifications of the movement patterns. So there you guys can see the contrast. The baby with the little hat is exhibiting normal movements, and the other baby is exhibiting cramp synchronized, which is highest risk for cerebral palsy. So again, cerebral palsy is very a prevalent condition here and worldwide, and the ideal state is shown in the green path. Early diagnosis, ideally before 5 months of age, early intervention, and optimized outcomes. As discussed, though, we're currently in the orange path with delayed and disparities in diagnosis, which as a result, delays in intervention. Further, the general movement assessment is a powerful tool to improve timing of identification, but is marred by significant barriers that have prevented its widespread adoption. And so it's grossly underutilized unless you're fortunate of having a baby at a large academic NICU. So our team's goals are to leverage recent advances in computer vision technology to bridge these critical gaps. So what is machine learning? So machine learning is a subset of data science and artificial intelligence that allows computers to make accurate predictions by finding complex patterns within data. And so our data is infants and their movement patterns. These techniques can be very powerful for large-scale deployment, specifically regards to the barriers preventing the universal implementation of the GMA, which includes expertise and a lot of resources. We also are making the argument that the test prior to hospital discharge after birth is critical to consider in order to address these barriers related to access to care. With this in mind, we are focusing on the writhing stage of general movements, a novel direction, as most of the research up to this point has focused on fidgety stage related to applying machine learning techniques. But that stage would miss the window of developing a universal newborn screening method for all babies everywhere to determine CP risk. Last year, we published our first model, which is based on these joint position data. And as you can see, we did fairly well in picking out babies with concerning cramp synchronized movements, though our false alarm rate was too high. Since then, we have improved our algorithm, and as you can see, with this improved algorithm, infant movements separate nicely into 3 standard categories: normal, poor repertoire, and cramp synchronized. In addition, the ability to pick out babies with those concerning movements has improved with a sensitivity of 92%. And most importantly, again, the algorithm is now excellent in screening out babies that do not have the concerning movement with a specificity of 95%. So for this proposal, we now need to move forward. Previously, we used videos that we had archived at our hospital, but we want to prospectively now validate this algorithm in infants that are cared for in our NICU and compare them to the general movement assessment, which is the gold standard. Secondly, we aim to develop a bedside app for visual representation of data. This is very important as we try to scale up this program and have access to this algorithm everywhere and in the United States and beyond. In addition, the data generated is completely de-identified, and this would also facilitate data sharing across sites and registries. In order to develop a user-friendly app, it also needs to be family-centered. So we will engage with caregivers as well as bedside providers to understand how an app can, one, assist with facilitating discussion and two, determining individual next steps for their baby and their family. So these are just two examples that we have, visual option 1 and 2, that may be options for the future. But with this study, other options may be identified. But it's most important that we can clearly identify the babies at highest risk, as well as start having conversations with the family about what that means. The app performance will be used and assessed with standardized surveys, as well as structured interviews with caregivers and providers. And so in the short term, the current project will move our algorithm into real-world prospective testing and lead to the co-creation of an app and key components for our long-term goal of establishing a newborn screening test for cerebral palsy risk for all babies everywhere, just like the newborn hearing screen. This approach is also key to fostering families' resilience, expertise, and autonomy. And you can see little Seven right here as he's grown up. So as we close, again, back to Seven's story. So Seven was born, like I said, extremely premature. He had multiple infections. He was very, very sick during his hospitalization. Luckily, he was cared for at UVA. So we have trainers that are certified in the GMA. We performed the GMA when he was around term corrected and noted to have cramp synchronized movements, got a brain MRI that did show abnormalities. And he was still in the hospital at 3 to 4 months of age, and we observed the general movements transitioning to absent fidgety. He was actually one of the first babies that Rich Stevenson and I diagnosed with cerebral palsy prior to discharge home. The family was so accepting of this diagnosis, and they really hit the ground running. So they started CP-specific interventions immediately after transitioning home. And at that time, we didn't know what the outcome was for Seven. You know, he was on a lot of medications, and we didn't know where he would fall related to his severity. But at age 3, he is a GMF-CS2. He is very talkative, and his parents are starch advocates for him. So let's make sure every child is afforded the same opportunity with universal CP risk screening prior to hospital discharge. Thank you. And this again just shows our team and highlighting Seven Rose's family for sharing the pictures and being part of our team, as well as Haley Stevenson is also has lived experience. She has a daughter with cerebral palsy as well. And these are my colleagues. Unfortunately, Santina Zanelli couldn't join us today as she's in Italy, but I welcome questions.
Oh, I mean, I would say fortunately she's in Italy, but
she had no internet service, and but something's going on in Charlottesville. I'm glad I was able to get through that without having my internet break out on us. So thank you so much.
Thank you so much. Does anyone have any questions? You can put them in the chat, or you
Amber had her hand up during the presentation.
Yeah, so the movement assessment that you're currently using, is that I can't remember the name of it, but I know Australia's been using it for quite a while and it's been quite successful. Is that the same movement assessment that you're using currently?
Yes, ma'am. That's the general movement assessment was published in 2017 as one of the gold standards for evaluating GMA at babies 3 to 4 months of age is kind of that sweet spot for helping towards an earlier diagnosis. Unfortunately, we learned very quickly with the pandemic that all the proctors are from Europe, and we have one amazing proctor and coming to have 2 in stateside. It costs a lot of money to get trained and maintain your certification. So every NICU across the country, unfortunately, does not have someone trained in that test.
Okay, how accurate is that test though?
That test is extremely accurate with upwards to 98% sensitivity and specificity. So identifying the babies correctly and identifying those that don't have risk for cerebral palsy.
So why, I mean, other than cost, why is it, and I guess that's a number one issue, but why isn't it just used more then and people aren't trained more if it's that. I mean, that's pretty good. 98% is really good.
Yeah, and that's at that 3 to 4 month mark. So it was never meant to be a universal screening. So we're kind of trying to take it to the next level and use the first part and convert it over. I will let you know that Europe is working hard to try to automate that fidgety stage at 3 to 4 months. The big problem with that we see is you have to bring the babies back. So that will miss a lot of babies. Our goal is that every baby would get a screen, just like the hearing screen and the newborn screen, and then have a plan for if they need close follow-up, referrals to early intervention, referrals to more specific interventions post-discharge.
And does that,
Hey,
does the,
hey, Amber, I think we're going to need to move on.
okay.
Sorry.
Amber, you can email me. I'm happy to have more conversations.
Okay, great, thanks.
Susan, I think you were up next, and then
I don't, so Elizabeth, I mean, I know we're running slow on time. We're getting behind. Are you good with another question or?
I think if y'all can just send your questions to me, I will make sure that the teams answer them and we'll share them back out. But yeah, well, we're getting close to 9 p.m. Eastern for me. So next up we've got Dr. Ed Hurwitz at the University of Michigan. He'll be discussing adult CP health and retirement study extension.
If you're speaking, Ed, you are muted.
Are you seeing my slides correctly?
Yes, we can.
Great, okay. Well, thanks everybody for this opportunity to present our project, Development of a National Survey of Adults with Cerebral Palsy, a unique opportunity for people with CP. My name is Ed Hurwitz. I'm one of the PIs of the project, one of the principal investigators, with my colleague Mark Peterson, the rest of our co-investigators, who I'll be introducing a little bit during the slides, and our community co-investigators, in particular, Jody Kretschmer and Duncan Wyeth. So in 2016, as Paul mentioned at the beginning of the webinar, we gathered together for a exercise of prioritization of research to be done by the Cerebral Palsy Research Network, and published this in 2018 as a patient-centered research agenda. The number one priority that came out was researching the issues around aging with cerebral palsy to understand not only how to treat adults now, but also to update and treat our treatment and therapies with children who have CP to prevent some of the future problems. Our group at the University of Michigan has been working and looking at adults with cerebral palsy for about 15 years now. Really, the question that comes up is, what is the so-called natural history of cerebral palsy? What happens when you go from childhood to adulthood? So we published on a number of areas related to this question. Mark Peterson, our co-PI here in the center, has helped lead this research. He's written about reframing cerebral palsy as a lifelong physical disability and talking about how cerebral palsy grows up. We've talked about the challenges of finding proper health care. We talked about transitioning health care for adults with cerebral palsy. Duncan Wyeth was a co-author on that paper. We talked about navigating the pathway to care in adults with cerebral palsy, involving our whole group, including Dr. Heidi Hoppala, pictured here, who's one of our co-investigators. We've also talked about function and health, including all the issues that adults face as they grow into adult, as children with CP go into adulthood, including pain, mental health, and the risk of chronic disease, which is higher in adults with cerebral palsy. So Cerebral Palsy Research Network has really been leading the way for the adult cerebral palsy data collection. Dr. Mary Giannotti, pictured up there in on the top on the left, has been leading the work with the Adult CP Registry, which comes through the MyCP website. And with that, we've been able to capture a lot of data, which has allowed us to write on questions about pain and functional loss. Dr. Christine Sarmiento also on top, Dr. Gary Norris on the left on the bottom, and Patrick McPhee. Dr. McPhee is an employee of CPRN who works with the registry, have all been helped with this work. So we've been able to capture people through MyCP who have signed up for the website, and we've been able to capture over 1,000 adults through clinic visits. But what about all the rest of the adults? There's a lot of people who go to clinics that we don't capture. There's a lot of people who don't know about the MyCP website. How can we reach further and include more people? So this has been a great question of professional interest to Dr. Peterson and I, but also personal interest as we're both parents of children with disabilities. I'm a parent of an adult with disability. There's my daughter, Meira, and Mark has a son, Marcus, who's 13 years old and has cerebral palsy. So this was important to us to see what happens as people with disabilities, particularly cerebral palsy, age and grow up. So we knew that a study like this, we would need to build up a big staff and a setup, an infrastructure that would cost millions and millions of dollars to set up. But what if that infrastructure was already built and just waiting to be used for adults with cerebral palsy? So this is the opportunity. The Health and Retirement Study is the largest and most comprehensive study of the general population of adults over the age of 50. It focuses on economic resources, health and healthcare services, cognition, work and retirement, and family issues. Now they're even collecting blood and tissue samples and psychosocial data, DNA and that kind of thing. And this study has an extensive infrastructure allowing for multimodal data collection, many ways to collect data, including these home visits to get biological samples. The data is collected about every 2 years. Well, the current Health and Retirement Study does not identify disability by diagnosis. So a cerebral palsy national survey will access the extensive current data collection infrastructure and focus on people with cerebral palsy. Even though the study that's going on now is 50 and over, the cerebral palsy extension can be expanded to be 18 and over and can focus on research questions chosen to fit the cerebral palsy population. The big opportunity here is that my institution, the University of Michigan, is the home for the Health and Retirement Study, and Dr. Jessica Fall, pictured here, is a co-investigator on this HRS study and on this proposed study that we're talking about tonight. So our objective is to ensure that there is robust co-production with a strong community voice in the design of a national survey of adults with cerebral palsy. So what are we going to do? First, we want to hear from the community. We're going to use a process called collaborative autoethnography. Well, what is it? It's using personal experiences and self-reflection as the data in a study and placing that data in a wider social context, in this case, looking at the population of adults with cerebral palsy. Why use this method? Because it brings the life experience of the people affected right into the science. And there's no special training required. You just have to tell your story. So who will be involved? 15 to 18 people with lived experience, adults with CP, caregivers, parents, with a diversity of functional level and age, as along with other categories of diversity. How does it work? Well, first we're going to develop an educational webinar and educational materials explaining the Health and Retirement Study, describing this technique of autoethnography, and it will be accessible. We'll work with the various participants to ask about their accessibility needs and account for those. And then we'll have 3 focus groups, 5 to 6 people each, and our community advisors, our community co-investigators have advised us that we should consider functional levels so that everybody will be comfortable and free to speak out. Again, we'll work on accessibility and we'll ask people to give their personal thoughts about these issues, and then we'll have collaborative reflection. The analysis will consist of coding the common themes from the conversation. We'll involve a community partner in this coding to make sure we're doing it correctly. And we'll ask that we'll look at the themes crossing the topic areas, not specific to each of the 5 topic areas I mentioned earlier, but just general themes that cross the whole expansion of the study. Then we'll have aim 2, which is setting priorities with the nominal group technique. That's a consensus group method. It involves brainstorming and idea generation. It involves decision making and prioritization. Well, why are we using that? It brings broad input into the decision process. It levels the playing field. It's a fair and systematic way of getting input. And who will be involved? 15 to 20 participants, including people with lived experience, like Jody Kretschmer, one of our co-investigators, clinicians, like Jessica Prokup, who's one of our co-investigators, and also in a sense a person with lived experience, and that she has a sibling with a disability, and researchers. And again, we'll look at diversity of function, and among the professionals, diversity of profession. And how will this work? Again, we'll do education. We'll share the themes that we developed in aim 1. We'll describe this technique. And we'll also talk a bit about how to develop specific actionable research questions so we can really hone in on the questions we want to answer for adults with cerebral palsy. We'll then have the group session where all participants will share their priority themes or research questions, going around the room and getting everybody's input so everybody will be speaking. Then we'll have discussion, clarification, and we'll address similarities. This will all be virtual, and again, addressing accessibility. And I should mention that virtual nominal group technique has been validated. Then we'll have the final prioritization, an online tool to rank 5 research questions, keeping themes in mind. Then we'll tally the scores to rank the questions, and then we'll have discussion and reflection to arrive finally at co-produced conclusions. And what will the deliverables be? We'll have vetted, prioritized research questions for a major grant called an R01 application to the National Institute of Health. Co-produced research is of higher value, and that's recognized by the NIH. We'll have co-produced manuscripts describing the process and conclusions, and presentations in national forums to promote inclusive research. So let's make a difference for people with cerebral palsy. This is a unique opportunity for people with cerebral palsy. It'll maximize the potential of 2 major infrastructure investments, Cerebral Palsy Research Network and the Health and Retirement Study. And by the way, there may be a potential benefit here for that community registry, as we think we may be able to use some of the information we gather to help inform the registry as well. There'll be a really robust community contribution to a major national study of adults with cerebral palsy, and we will finally be answering the questions that will define the best care through the lifespan. I really thank you for your attention, and I'll be willing to take any questions.
All right. Thanks so much, Dr. Hurwitz. Anybody questions? All right, we're going to wrap up then.
Wait a minute. Amber's got her hand up.
Sorry. Go ahead, Amber.
So how is this study gonna piggyback on what we did in 2017? Like, what are the differences versus the similarities in how it's going to look at the issues for adults with CP and go beyond just having research questions, but actually, and then doing the research, obviously, but actually having, I guess, evidence-based answers to that where they can actually be used in practice?
So this study will, differently than what we did in 2016, 17, 18, will be focusing on what the capabilities are of the health and retirement studies, which are massive. And we'll be looking at what kind of information they're gathering and how they gather it, and how we can do that for adults with cerebral palsy. With those things in mind, we'll be applying for the larger grant, which will allow us to actually do the research, to use the infrastructure, and to start gathering the data we need to answer those questions. Does that help, Amber?
Yeah.
Great.
Susan?
Hi, class of 85, School of Social Work, go blue. How do people sign up for your study?
Well, that's a great question, Susan. We will be looking at our community advisory council to recruit people. We will be getting advice from them about who should be coming in. We'll be putting the word out about it, and I think that's how we'll get people into the study.
Thank you.
Okay.
All righty.
All right. Is that everybody? Okay. All right. So let's talk about what happens next. Can everybody see that screen?
It's coming. There you go.
Okay. So we're going to send out an email with a link to your ballot along with a recording of this webinar tomorrow. Voting closes on Sunday, October 5th at 11:59 p.m. Eastern. CPARF will announce the winner on Friday, October 10th through email and our social media channels. If you're not already a Changemaker, or if you have any questions, please reach out to Christy at christy.hagen@cparf.org. Thank you for being a part of our first Changemakers Grant Pitch event. Thank you for being part of a community of donors who believe in the power of science to transform the lives of people with cerebral palsy and other disabilities. Thank you for helping us reimagine all that is possible. I hope everybody has a great night.
And let me just conclude and say thank you to all of the investigators, all those of you who presented here tonight, and those that actually contributed their efforts, even though they were not selected for this final round. And I really appreciate the folks at CP Alliance Research Foundation for making these grants possible within the CP Research Network. It's really a great and motivating thing, especially in these hard times to get funding. So thank you all so much. Have a good evening.
Thank you.
Thanks, everybody. Thank you.